Welcome to Cardio Insights, the podcast where we explore how digital solutions are transforming cardiovascular and emergency medicine. Featuring thought leaders from leading institutions across the globe, this series of conversations unveils the power behind clinical algorithms and decision support tools, and how they are changing the way we diagnose and manage cardiac conditions. From their impact on clinical practice, their benefits for patient outcomes, and the challenges they pose to health systems in terms of implementation and regulation, this podcast is intended as a precious resource for healthcare professionals in cardiology and emergency medicine who are curious to learn more about this exciting field. I'm your host, Matthew Chaffert, and you are listening to Cardio Insights. So welcome, Professor Boddy, to this episode of Cardio Insights, the podcast where we explore how digital solutions are transforming cardiology and emergency medicine. For our listeners who might be new to you, you are a professor of emergency medicine, a honorary consultant in emergency medicine and group director of research and innovation at Manchester University NHS Foundation Trust. Next to your teaching activities and clinical practice, you also serve as a member of the Committee for Clinical Applications of Cardiac Biomarkers with the International Federation for Clinical Chemistry. Throughout your career, you have published over 200 peer-reviewed publications, and your research focuses on acute coronary syndromes, diagnostics, clinical epidemiology, biomarkers, and the philosophy of emergency medicine. In this episode, we want to, explore with you what's your perception on, the use of digital solutions in your practice, and also, the methods and the techniques we use to evaluate these tools and, the impact that they have on patient outcomes, and, that the challenges that evaluating these tools poses as well. So the first question I have for you is, if you could give us an overview of what type of digital solutions you use in your daily practice and how your work has also evolved over the past years with the emergence of new solutions.
Yeah, sure. I got into this area by being interested in the development of a digital tool, actually, which ultimately became the decision aid called TMACS, the Troponin-Only Manchester Acute Coronary Syndromes Decision Aid. And our idea was to use troponin as one component of a clinical prediction model, but to pull in other information from a patient's symptoms, past history, and to take a sort of data-driven approach to this, so that we'd use the information that gives us predictive value and combine it in the optimum way to calculate the probability that our patient has an acute coronary syndrome on an individual level.
Yeah.
We'd handle troponin as a continuous variable, or at least we were open-minded to using troponin as a continuous variable. I mean, I think we had to explore the data to see if that was the best way to use it. And it turned out it was, no cutoff, that troponin behaves best for predicting the probability of acute coronary syndromes when we handle it as a continuous variable. So we derived this prediction model, and then we've evaluated it in multiple validation studies. We implemented it in 2016. I led a project to implement this across our region in Greater Manchester at 12 hospitals after that. And we've been using it successfully since then. I think that it has some particular advantages, actually. I really like the fact that we get an individualized probability. It informs me as a clinician as to the individual risk for my patients. It allows me to share that with my patients as well, to engage in shared decision-making. And it tells me what to do. So if I just use the test in a dichotomous way, positive or negative, there's so much uncertainty in that. The positive predictive value of a troponin above the 99th percentile is actually relatively low. And the negative predictive value below the 99th percentile is not that high. But when we bring in all of this information, it's much more rich. The first decision we've got to make in the emergency department is whether the patient needs to stay with us for more investigation or go home. And we can use troponin in a dichotomous way to do that. That's fine. But there's so much more that we've got to do. We've got to decide whether they're coming into hospital. And if they are coming into hospital, where do they go to? Can they go to an ambulatory care area, or do they need to go to a coronary care unit? And when you've got a digital tool that sort of gives you a continuous variable as an output with probability, it allows you to make those decisions with a much better evidence base than if you just dichotomize results or impose any cutoff.
Yeah, understood. And, if we shift gears towards the the understanding, what's the evidence that's needed to, support the use of these tools and how this evidence is built. Can you take us through in maybe, following the example of that project that you worked on and that tool that you developed, how you came about building the evidence that would, eventually create the trust towards other practitioners to use that and, be, let's say, get a broader use in the cardiovascular and emergency medicine community?
Yeah, sure. I guess, it starts with refining your research question, deciding what you want this tool to do, and setting that out very clearly, because that's going to inform your whole approach to evidence generation. For us, the key thing was to decide who's coming in and who's going home, but then to risk stratify the ones who are coming into hospital. And then you set about doing your studies, observational studies initially, to derive the decision rule. So you want to include the patients who are going to have the condition suspected, collect all of the data that you're going to need, and then use your usually machine learning techniques to derive the optimal algorithm. The next step is to validate that externally in different populations. And again, that's usually done in observational studies, diagnostic test accuracy studies. And many decision aids actually stop there.
Yeah.
We get the observational data. And some of the recent ones have been derived and validated in really large cohorts, tens of thousands of patients, which is fantastic because that increases external validity. But we often stop there at the observational data. And what we really need to know, I think, is to go a little step further. How does it actually change patient care? And so for that, we probably need the interventional studies, randomized controlled trials to see, does it actually affect patient outcome? When we actually use it, can we get more patients home safely from an emergency department than we would if we just used troponin by itself, for example? And can we make better decisions for those who are coming into hospital, be more selective about the use of PCI, for example?
Yeah.
And then we can go even further than that, than an RCT. There's plenty more to talk about.
And why do you think we stop, in most cases, at the observational study level? Is it a lack of means? Is it the complexity that's implied with running clinical trials? Why is that?
Well, a good external validation study is the bare minimum that you need for implementation.
Yeah.
And I'm fine with that. I think that's okay because you don't want too much inertia. It takes too long to get innovations out into practice.
Yeah.
There's a statistic that goes around saying that on average it takes 17 years from innovation to adoption into practice.
Huge, yeah.
And if for every innovation we're taking 17 years, the pace of change in healthcare is not going to be very fast. So I'm all for, being an early adopter after you've got the robust data that show accuracy implemented in practice. But at the same time, as we've implemented in practice, to get findings that people trust and on a wider scale, to get more general implementation, I do think the RCT plays an important role. If I reflect on my experience with TMACs, for example, I don't think we've got that wide adoption. I think the heart score is better utilised internationally than the TMAC score. And yet when we've done direct comparisons, TMAC is more accurate, gives you better risk stratification. So why is that? And maybe it's because we didn't do the RCT to show that actually the use of this will actually change decision making and make us more effective in practice, to show that it's cost effective. So I do think it's an important step, hopefully in parallel with clinical adoption for the early adopters. But I don't think you can ever replace the RCT. There are alternatives. As the field moves, maybe people could take the example of people like Martin Than in New Zealand leading the iCare project, where they're doing a sort of step wedge implementation for point of care testing. And this is kind of real world data. So they put the point of care tests in practice and then evaluate how it's going outside of the context of an RCT.
Yeah.
And I'd love to see more methods like that. If we can robustly evaluate effectiveness and cost effectiveness using such real world approaches, I think that would be a real step forward for us.
Yeah, it accelerates in a way as well the access to innovation, where you mentioned, 17 years, it's like, a generation almost. And, when we were preparing the conversation, you also touched on the importance of evidence that's generated, towards, that would speak, more for patients rather, for clinicians as well, but beyond, let's say, the pure clinical evidence in terms of the efficacy. What can you, share with us in terms of what are some of the metrics that matter or that we should make transparent to patients with regards to the use of these tools. And yeah, it would be interesting to hear a perspective on that.
Yeah, I mean, I think this is far from a done deal that is decided in the field about what outcome measures we should use. But if you think about it, when we're evaluating a digital tool, we look at efficacy. And when we talk about efficacy with a diagnostic test, we're generally thinking about measures of diagnostic accuracy like sensitivity, specificity, the proportion of patients that might be discharged appropriately, that kind of thing. And we may look at effectiveness, when we actually use this in practice. How many people get home and what are the outcomes of those patients in terms of prognosis, major adverse cardiac events in the future, and cost effectiveness. They're the sort of quantitative outcomes. But I think there's so much more to it than that. You mentioned the patient-related experience measures that we could use. So I'd be interested to know, how do patients feel? One of the key advantages of a digital tool is that we could potentially empower patients with more information about their condition and allow them to play a more active role in their care through a shared decision-making approach. We can get richer diagnostic information through digital tools. Why don't we share that with patients and allow them to engage in the decision-making process? And if we do that, how do they feel about it? What's important to them about their care? And are we able to do that better through the use of a digital tool than we would just through using a raw diagnostic test with dichotomous results?
Yeah, understood. And you touched on the relevance of real-world data and real-world evidence, mentioning the work from your colleague, Professor Martin Tan, that we also got on the podcast in another episode. How do you see real-world evidence and real-world data helping to evaluate and also provide faster access to innovation for clinicians or hospitals across other, maybe potentially beyond cardiovascular and emergency medicine as well?
Well, one of the big problems we've got with evidence generation at the moment is that, we've talked about this, we do the bare minimum. We'll do the external validation. We may even do the RCT, and it will show efficacy or effectiveness for the whole group as a whole. Yeah. And we know how it works with a one-size-fits-all approach. But increasingly, we're recognizing across health and care that this can leave people behind. We get gender inequities. We get disparities by ethnicity, by socioeconomic deprivation. When we talk about digital tools, there's important elements of digital exclusion.
Exactly, yeah.
There may be differences in performance by age or comorbidities. And it's really difficult to explore those in an RCT because you power your RCT for the whole group, for subgroups. So your analyses in the subgroups are always going to be underpowered. And that's where I think the real world data comes in and is so important. We don't want to slow the pace of innovation down so much that we get so much inertia that we can't adopt until we've run powered RCTs for every single important subgroup.
Yeah, it's not sustainable.
It's not going to be possible, is it? We wouldn't have any innovation. It would just literally not happen. But what we could do is commit ourselves to saying, well, actually, once we've got enough data to get this over the line and adopted, we need to be sure that we do sort of the phase 4 evidence generation, where we collect data in the real world and that in a larger number of patients. And with the informatics infrastructure that we have nowadays in high-income countries, it should be possible for us to collect that data and explore how digital tools are performing in all of those different important subgroups. And that would then allow us to refine the digital tools to make them more personalized for each subgroup. And ultimately, when you have a large enough sample, you can really tailor the outputs of these digital tools to the individual based on their personal characteristics.
And I was also asking myself, in light of, let's say, the use of wearables that are, they also provide, very interesting information now in terms of ECG, in terms of heart rate, potentially blood pressure as well. I guess it also makes the acquisition, the treatment, and obviously the execution of these sort of like decentralized trials more accessible than, let's say, a standard randomized control trial. So there's also a cost benefit of running these types of studies that add to the evidence base that we have for these solutions.
Yeah, totally. And, it's such a complex field, but with digital tools, things like you mentioned, the wearables, I mean, as our population ages and has increasingly more comorbidities and comes in with more complex health problems, and our hospitals fill up and emergency departments get crowded, we need to think about new ways of delivering care. So in the UK, there's a big drive for community-based care, hospital at home and things like that. So wearable technology that allows us to monitor patients as well as we would in hospital, but in their own environment, become increasingly important. And when we think about digital tools, it'll be increasingly important to be able to assimilate that data with our digital tools. So we can bring in information from all sorts of different sources, including wearables, and get sort of dynamic risk prediction that will inform the care of patients wherever they are.
Understood. We have a recurring question we ask every guest that we have the chance to have on the podcast. And, you can bring some fantasy to the discussion in a way. But if you had a magic wand, which digital solution would you like to have in your clinical practice that's currently missing, beyond, let's say, the solutions we've talked about in our conversation?
Well, I'd like my perfect decision tool to use a sort of large language model so that we could talk to it.
Okay, yeah.
I can imagine, ChatGPT, you realize the possibilities with the generative AI. And that sort of solution would be amazing. So as a clinician, I could see my patient. We could have ambient documentation. So it's listening to the consultation. It's relaying it back to me. It's interpreting the consultation. When I come up with my theory about what is happening with the patient, I'm going to get some validation from the AI model.
Or be challenged.
Challenged, exactly. Make me think about things that I haven't considered. When I get my diagnostic information back, it's going to help me to apply the digital tools, and it's going to help me interpret the information from that in terms of the probability, weigh up the risks and benefits in a data-driven way. If I decide I want to give the patient antiplatelets or go for angiography, then it's going to help me to weigh up the risks of those treatments against the benefits, given the uncertainties that are inherent in information that we've got. And I think that then it could allow us to integrate that with our communication with the patient so that we can give them something to go away with. If we send someone home, for example, and we say, actually, it's not a heart attack, you don't need to worry, it's going to be fine for you to go home. Patients often express dissatisfaction, and we say, it's not a heart attack, you can go home. We don't tell them what it is. We don't tell them how to stay healthy. We haven't addressed the fact that they're smoking 40 a day or not exercising, or there are lifestyle choices that they could modify to stay healthy for longer. And we could integrate that with this digital tool so that there's sort of some ongoing follow-up and education for the patient that empowers them as a sort of active player in their healthcare rather than a passive recipient.
Yeah, makes a lot of sense. Thank you so much, Professor Boddy.
Thank you very much.
Thank you for listening to this episode of Cardio Insights. We hope you enjoyed it. If you want to dive further into other aspects of digital solutions in cardiovascular and emergency medicine, check out the other episodes of the series. To support the show, you can share this episode with your surroundings and leave a 5-star review on your preferred streaming platform. Cardio Insights is a podcast brought to you by Roche. Thank you for your time, and see you in the next one.